start your presentation now. Go ahead.
Thank you very much. The topic of my presentation is the role of peritoneal carcinomatosis index in the treatment strategy for advanced stages of serous ovarian cancer.
So you can maximize your window. You can maximize.
Maximize. Okay. Now. Okay. Is that good?
Again, it's opening.
Do you see the slide?
You can see the slide, but it is not in full screen mode.
You don't see the slide.
We can see the slide. But it is not in full screen. Okay, no problem. You can continue. Okay.
Ovarian cancer is one of the most aggressive and complex diseases of female genital area. More than 3,500 new cases of disease are registered yearly in Ukraine, and 22.7% of patients die within the first year after diagnosis. According to updated data from National Cancer Register, 3,545 cases of ovarian cancer were registered in 2019. What is peritoneal carcinomatosis? It's a type of metastasis of malignant tumors manifested by lesions of parietal and visceral peritoneum by tumor nodules of different diameters. Peritoneal carcinomatosis is considered as disseminated form of cancer when the primary tumor loses its lesion value and the signs of metastatic lesions of various organs and systems prevail. There are several ways to develop and spread of peritoneal carcinomatosis: implantation or transmesothelial, lymphogenic route of transmission, hematogenous. The division into peritoneal carcinomatosis pathways does not preclude a mixed mechanism of peritoneal lesions. And the term of peritoneal carcinomatosis is very closely combined with the name of prominent American surgeon Paul Sugarbaker. He and his team in early 80s of last century approached the peritoneal carcinomatosis as a local intraperitoneal, not metastatic process. The biological model of this approach has become tumors of the appendix, leading to pseudomyxomas of peritoneum. In this disease, tumor cells spread through the peritoneal fluid to abdominal cavity in the expected order, in the large omentum, in the peritoneal of diaphragm, on the surface of the intestine, in the ileocecal angle and pelvis. And he developed basic principles of surgical treatment of peritoneal carcinomatosis. They are: the selection of patients is based on good functional status according to absence of hematogenous and extraperitoneal metastasis. The operating surgeon has sufficient experience and strives to perform complete site reduction without the presence of a visually identifiable residual tumor. The tumor is removed by peritonectomy with possible multi-organ section. Small and large intestine, bursamentectomy, splenectomy, cholecystectomy, removal of the liver capsule. And here you can see how to calculate peritoneal carcinomatosis index, PCI. You should use formula CF. CF is the size of tumor foci or lesion size. You can see lesion size 1, it's a tumor less or equal 5 millimeters. Tumor size, lesion size 2, it's a tumor from 5 millimeters to 5 centimeters. And lesion size 3, it's a tumor that's greater than 5 centimeters in the longest diameter. So size of the tumor foci you should multiply on n. What is n? N, it's a number of anatomical areas affected by tumor. Here you can see abdominal cavity and its anatomical area from 0, it's a central area, to 12, it's a lower ileum area. So peritoneal carcinomatosis index can take values from 0 to 39 points. According to current data, it is desirable to begin treatment of advanced ovarian cancer with primary debulking surgery when surgical treatment is preceded by chemotherapy. Why? Because potential benefits of primary debulking surgery include, first, removal of fully vascularized tumor mass, which is the place of limited access for chemotherapeutic drugs. Second, residual tumor that may remain after site reduction is characterized by better blood supply and greater production of growth factors, which increases cell death during chemotherapy. Low residual tumor mass requires fewer cycles of chemotherapy, which reduces the likelihood of induced drug resistance. Removal of drug-resistant collagen cells, and the last, the immunocompetence of the host organism increases with the removal of a larger volume of the tumor. And here you can see a classification of cytoreductive operations by degree of radicalism. They are complete cytoreduction, optimal cytoreduction, suboptimal cytoreduction, and non-optimal cytoreduction. Complete cytoreduction is an operation without macroscopically visible residual tumor after the surgery. Optimal cytoreduction, it's a surgery with a residual tumor up to 1 centimeter. Suboptimal cytoreduction is an operation with a residual tumor from 1 to 2 centimeters. Non-optimal cytoreduction is an operation with a residual tumor larger than 2 centimeters. A study by an ecological cancer group, which covered more than 3,000 patients with ovarian cancer from 2B to 4th stage, showed that when performing complete cytoreduction, the life expectancy of patients reached almost 100 months. At the same time, with a residual tumor up to 1 centimeter, optimal cytoreduction, it decreased up to 36 months. At the size of the residual tumor more than 1 centimeter, survival did not exceed 30 months. Therefore, the presence of a residual tumor after cytoreductive surgery is an important prognostic factor. Multiple surgical procedures are required to remove all visible foci of the tumor. Only the achievement of complete cytoreduction should be the goal of surgery before polychemotherapy. However, neoadjuvant chemotherapy may be a reasonable alternative for patients with stage 3C to 4th disease. Compared with primary cytoreduction, neoadjuvant chemotherapy increases chances of complete cytoreduction. And in 2001, a prominent European surgeon, oncologist Ignaz Vergote, proposed criteria for selection of patients with advanced ovarian cancer for whom treatment should start with a neoadjuvant chemotherapy followed by interval cytoreduction. They are tumor more than 2 centimeters around the superior mesenteric artery or behind the porta hepatis, the presence of intrahepatic metastasis or metastasis in extraperitoneal lymph nodes, except for resectable metastasis in inguinal or supraclavicular lymph nodes, poor general somatic condition of the patient, usually extensive surgery with presumed bowel resection more than 1.5 meters, patients in whom 2 long interventions will be expected in advance. For instance, one stage of operation, such as bowel resection, will take more than 3 to 4 hours. So he concluded that aggressive surgery should be adapted to general condition and degree of the disease of patients to reduce the incidence of postoperative complications and mortality. According to a study by Japanese scientists in 2020, among 36 patients with PCI from 1 to 10 in primary department surgery, complete cytoreduction was achieved in 86% of cases. Optimal cytoreduction was in 8% of cases and suboptimal in 6% of cases. While among the 20 patients with PCI from 11 to 20, the moderate index, complete site reduction achieved in 75% of cases, and optimal site reduction was in 25% of cases. And among 4 patients with a huge PCI from 21 to 39, complete site reduction was achieved in only 25% of cases, and in 75% of cases, it was optimal site reduction. When performing interval debulking surgery in the group of patients with lower PCI from 1 to 10, complete site reduction was achieved in 100% of cases in all patients. At moderate PCI from 11 to 20, complete site reduction was achieved in 96% of patients. Optimal site reduction was in 2% of patients and suboptimal in 2% respectively. And at PCI from 21 to 39 points, complete site reduction was reached in 85% of cases. Optimal site reduction was in 10% of patients and suboptimal in 5% of patients. So we can come to conclusion that peritoneal carcinomatosis index is a predictor of potential tumor resectability. The aim of our study is to analyze the results of treatment of patients with primary advanced serous ovarian cancer with a high peritoneal carcinomatosis index, PCI greater or equal to 12, and such indicators as the degree of aggressiveness of surgical interventions, postoperative complications, length of stay in the intensive care unit and hospital, timing of adjuvant chemotherapy compared with a group of patients with a lower index of peritoneal carcinomatosis, PCI less than 12 after site reductive surgery. An analysis of results of treatment of 50 patients with advanced serous ovarian cancer who were treated in the Department of Oncology of National Cancer Institute from 2016 to 2020 was conducted. In this table, you can see general clinical characteristics of our patients. 25 patients with advanced serous ovarian cancer had a high index of peritoneal carcinomatosis. It was study group, and 25 patients had a lower index of peritoneal carcinomatosis. It was control group. It was used surgical complexity score evaluation system to assess the extent of performed surgery, which provided quantity assessment of each surgical procedure. Each patient received points according to the volume of performed operation. Adjuvant polychemotherapy, according to TC protocol as a standard first-line treatment for ovarian cancer, included intravenous carboplatin and paclitaxel every 3 weeks. Standard methods of descriptive statistics were used for data processing. And in this table, you can see a surgical complexity scoring system in debulking surgery in our ovarian cancer patients. In that table, you can see the distribution of patients with ovarian cancer depending on the volume of site reductive surgery. You can see that complete site reduction was performed in 76% in the study group and in 80% of control group. The groups were statistically homogeneous. Site reductive operations of median complexity included hysterectomy with bilateral adnexectomy, omentectomy, pelvic peritonectomy, stripping of the diaphragm, appendectomy, cholecystectomy. High complexity surgery included hysterectomy with bilateral adnexectomy, omentectomy, stripping of the diaphragm with resection of central tendon of the diaphragm, low anterior resection of the rectum, removal of tumor foci and the mesentery of the ileum and ascending fold, ileal resection, and epidectomy. We analyzed the results of treatment after cytoreductive surgery in patients with primary advanced ovarian cancer in the study and control group according to the following indicators: the degree of aggressiveness of surgery, postoperative complications, the length of stay of patients in the intensive care unit of hospital in terms of the beginning of adjuvant polychemotherapy. So we investigate the degree of aggressiveness of cytoreductive surgery in patients of study and control group at the end of the first day of the postoperative period using such physiological parameters: creatinine, total protein, alanine aminotransferase, and aspartate aminotransferase. And in this table, you can see that according to such physiological indicators as alanine aminotransferase and aspartate aminotransferase, in the group of PCI greater or equal to 12, that indicators higher, and the difference between study and control group is statistically significant. Next step was investigation of postoperative complications. The most surgical complications were failure of Sims, pleurisy, colostomy necrosis, bleeding. And the most common non-surgical complications were mild to moderate anemia, severe anemia, toxic liver damage, acute kidney damage, gastric stasis or paralytic ileus, and keratitis. And in this table, you can see that such complications as pleurisy, mild to moderate anemia, severe anemia occurred in study group more often. And the difference between study and control group, according to these complications, was statistically significant. The analysis of immediate treatment results. We analyzed such indicators as duration of stay in the intensive care unit, duration of inpatient treatment after surgery, terms of starting treatment with adjuvant chemotherapy. And in this table, you can see that according to duration of stay in intensive care unit and duration of inpatient treatment, in the we see that indicators in study group with the PCI greater or equal to 12 higher, and the difference between study and control group is statistically significant. We think that longer postoperative treatment in the intensive care unit and hospital in patients with PCI greater or equal to 12 may be associated with greater surgical trauma during cytoreductive surgery in such patients, and more frequent occurrence of complications of surgical and non-surgical process in that. Conclusions. Cytoreductive surgery in patients with peritoneal carcinomatosis index PCI greater or equal to 12 is a highly aggressive treatment that adversely affects the functioning vital organs and systems of patients. Pleurisy and severe anemia are the most common complications in postoperative period, which is significantly more common in patients with high index of peritoneal carcinomatosis after cytoreductive surgery. Cytoreductive surgery in patients with high index of peritoneal carcinomatosis prolonged terms of postoperative treatment both in intensive care unit and in hospital in general. High index of peritoneal carcinomatosis in combination with doubtful prospects of complete cytoreduction, the presence of severe comorbidities, are the selection criteria for neoadjuvant polychemotherapy in the treatment of the stage 3C to 4 of ovarian cancer. Thank you for your attention.
Thanks, Leaoroy, for your informative presentation. Any question from audience side? Okay, so we can move to our next presentation. I would like to call upon Aram Abbas from Damascus University, Syria, to deliver.
Sorry, may I ask questions? Sorry, please. I want to make one question to Mykhailo Egorov. Oh,
yes.
Oh, yes. Thank you very much for your presentation. It was very interesting for me, especially. And I have one question. In our practice, we don't often use PCI for staging of peritoneal lesions. This doesn't affect the choice of treatment. Do you think peritoneal carcinomatosis index should be used for all peritoneal tumors, or it is not the standard approach? For example, not only for ovarian cancer, about mesothelioma or inclusion cyst, about my presentation, or it is not standard?
Thank you very much for your question, Tatiana. I can speak only about our oncogynecological standards, and we know that ovarian cancer it's a disease which we usually diagnose on advanced stages, 3, 4th, or even 2nd, and it is usually and the peritoneal carcinomatosis is very usual in ovarian cancer, and we know that the treatment, the surgical treatment is a very important part of the treatment of this disease. And for oncogynecologists, it's a challenge from what method we should start, from surgical or from chemotherapy. And in oncogynecology, we use PCI, peritoneal carcinomatosis index, to have a decision. If we have low peritoneal carcinomatosis index, it's less or equal to 12, we should start with the surgery. But if we have greater peritoneal carcinomatosis index, it's better to start with a neoadjuvant chemotherapy. I'm speaking about ovarian cancer, not about mesothelioma or peritoneal inclusive cyst.
Okay, thank you. Thank you very much.
Thank you for the question.